all these studies that in the past have shown both the prognostic potential of ctDNA or liquid biopsies, or early marker recurrence, or even predictive marker in terms of benefit from adjuvant chemotherapy and all that stuff. A lot of those have been like retrospective looks on prospectively collected samples. None of those patients had results available in real time. So the BESPOKE study was the first prospective study in the United States using a tumor-informed circulating tumor DNA assay, in this case, the Signatera assay from Natera, which was the sponsor of the study, to help prospectively assess the utility and value of ctDNA in these patients. So, in terms of guideline change, in terms of providing more value, while retrospective studies are helpful in terms of hypothesis generation and coming up with study questions, but to change clinical practice and to provide, more tangible updates, usually any kind of prospective study or randomized controlled trial is what's warranted. At the time, using ctDNA as an integral biomarker, the field was still, it's embracing now, to your point, as you said, but 3-4 years ago that wasn't the case, and you could even use the word circulating tumor DNA without being interrupted because people didn't even believe in it, if it was something that was even feasible or validated, or sensitivity and specificity was in question. We didn't even know of numbers. So this study was the first prospective attempt in the United States to provide a benchmark for what to expect in terms of MRD or ctDNA positivity in stage 2, 3, and then also study their outcomes. The other motivation, as you asked earlier about the study here, was to also see if, how do patients value this? There's a lot of myth about, ctDNA increasing anxiety, ctDNA not helping patients. Is it just bad news? So this also was something that helped validate those questions in terms of how much patients, on the opposite, actually valued the utility of ctDNA in their care. So this was a prospective study that was done at over 130 sites across the United States. So in terms of the study accrued like almost 1,800 patients, about 70 patients a month over 2 years in the middle of pandemic. So the 133 sites were sites that are both community as well as academic centers who see patients with colorectal cancer. For the study, initially, it was focusing on patients with stage 2 and 3 colon cancer on their pathology who otherwise, were fit enough to get surgery and were fit enough to have potentially, any kind of therapy moving forward. So kind of like the standard, but relatively flexible rule apply, because, you could still have somebody with stage 2 cancer with no chemotherapy. So getting chemotherapy wasn't necessarily an inclusion criteria, but having a stage 2, 3 colon or rectal cancer that underwent surgery that you had the pathology report to confirm with was an inclusion criteria for the study. And the goal of the study was to see what happens to these patients in terms of recurrence, as you pointed out earlier, decisions for chemo, and also how in real time that decision is changed based on the results of the ctDNA that were provided in real time. So all these patients who were getting ctDNA testing was done in real time. So the patients were getting, and their providers were getting the results back within 4 to 6 weeks. In fact, one of the things I often say about liquid biopsies is it is a tool to decentralize clinical trials and research, because it's not like this study can only be done at Cornell, or can only be done at Sloan, or can only be done at MD Anderson. This study could have been done at any community or academic site that could just collect 2 tubes of blood and can ship the tumor sample to the company that designed the assay. So it was very basic and simple. So it all boiled down to how many patients and sites we needed to complete the study efficiently in a couple of years, with a goal of 1,800 patients in mind. I think this study set the benchmark, at least knowing how many patients with stage 2 would you expect to be MRD positive, and that was about 6%, 6.5% or so. And then for the stage 3, it was almost triple, so it was like 21.8 or 22 or 21% or so. So it kind of provided that benchmark, and it seemed like whether or not, if you were stage 2 or 3, as long as you were MRD negative and then stayed negative. These were patients where 92% of them were cancer-free at 2 years. On the opposite, the contrary, if you were MRD positive, less than a third were cancer-free. So and again, if you look at months in terms of disease-free survival, medians, it was not even reached because patients were doing so well if they were MRD negative, to less than 16 months if you were MRD positive. So it kind of provides that benchmark. And to your question about benefit from chemotherapy, what is provocative is, and this builds on the Galaxy study from Japan, which was also presented at ASCO with an update. In the MRD negative patients, there was virtually no difference that was statistically or clinically significant, whether or not you got chemotherapy or you were just observed. So the median disease-free survival was not reached for both the groups. And as opposed to like the 2-year benchmark they often use for colon cancer, because most of the time if cancer were to come back, they come back within a couple of years. Similar numbers were cancer-free, over 90%, if they were ctDNA negative. So while we're not ready to kind of not give chemotherapy to somebody who is cancer DNA negative, but it's provocative that ongoing studies that right now are, for example, randomizing you to chemo versus no adjuvant chemo. When these studies were being done or being proposed several years ago, there were discussions or comments like, this is unethical, I wouldn't be comfortable in doing that, and all that kind of stuff. At least this provides the rationale that, okay, maybe, to a patient with stage 3 cancer, I'm not going to say no chemo, even if the test is negative, but at least if there's a trial that's randomizing to observation only, this study data set provides a pretty good benchmark or numbers that patients can then themselves make the decision if that's something that they want to do or not. And then for MRD positive, again, that's where I think these tools are getting more beyond prognostic to being predictive markers too. Because if you didn't do chemo, if you were MRD positive, only 12.5% were cancer-free at 2 years. And this number was almost tripled or quadrupled if with adjuvant chemotherapy to almost half as many patients being cancer-free. So it was about 42%. And I think let's send a message there also is the unmet need for better drugs or chemo, because it's not the test that's the problem. We need better drugs, and that's where some of the trials are looking at escalating of chemo or doing triple chemo versus double chemo, or I think this is also a perfect or right position for clinical trials to pair with novel drugs. So you could spare the toxicity to the negative folks who don't need any additional therapy, maybe focus and escalate your energies to the ones who are positive. The trends and the message and the common themes are very similar, except for more updated cohorts. So for example, in the expanded data set at the time of it was on close to 689 patients with complete data. So it was over 600 as opposed to the over 300, and there's more additional analyses for the total of 1,800 patients that were accrued with stage 1 and stage 4 combined as well. So overall, the overarching themes are the same. MRD positive, probably the most powerful prognostic variable that we have. I think with larger data set, the confidence interval was more refined and precise, but in terms of benefit in ctDNA positive and virtually no benefit in ctDNA negative, the disease-free survival of, in terms of if you got chemo versus you didn't get chemo, the benchmark for MRD positive that, as I mentioned, we also provided some additional information, like, for example, ctDNA is a dynamic variable, so you could be positive and then turn negative transiently and then turn positive again. So this transient clearance, also, it's important in terms of patients, how long do I need to keep worrying about this, that my ctDNA will turn positive? It seemed like if it were to become positive, 85% of the time it was within the 15th month. So I think that was an important number that we identified as well. We also presented updated results on the patients who had recurrences. So in about 100 patients who had recurrences, in about 40 of them, recurrences were in what we call or were oligometastatic in nature. Oligo is a Greek word for few. So in patients with stage 4, even metastatic cancer, as long as it's in 1, 2, or few places, we still go after them with surgery, resection, ablation, radiation to render them cancer-free or NED on the scans. And we were able to do that in about 40% of the cases. That was an important finding that was not in the initial submission that we were able to present at ASCO GI, as well as that more than half of them were cancer-free in terms of long-term follow-up. So, picking up cancer early, if we can act upon it, it seems like we're making potentially a difference. We'll have more updates with long-term follow-up and study as it matures. But I think the other thing that we presented at ASCO, which was part of the whole separate patient-reported outcomes poster, was that the perceived utility. So on the contrary, that ctDNA increases anxiety, our findings were that 73% of the time, patients actually reported that their anxiety actually went down about recurrence. Because if you think about it, if they were cancer DNA, ctDNA free, they overall had less anxiety. And about 90% of the time, they felt that they were receiving the right treatment, that they would continue using the test, that they valued the additional information. We captured many domains of fear, anxiety, depression, value, utility, confidence, which I think was also helpful for the field. We actually even developed a questionnaire that already have been asked several times, and I think it's something that future studies could incorporate into their studies.